Hello everyone, welcome to day 5 of our challenges series. We had skipped a days, so we'll hope to make it up in the following days. Just answer the questions in the comment box and you will get the answers in the next session once the comments are being posted. The first question for day 4 was a diabetic male presenting with the following lateral view of x-ray of foot. You need to identify the pathology. Second day was a patient who presented on POD 4 of surgery. Identify the structure or the pathology in this case. Next question was identify the mimic this following CT is presenting. You need to identify the sign and the mimic of that sign, which is being shown in this diagram in this CT image. Next, you need to identify the anatomical structure and the pathology associated in this image. And fifth was to identify the study and also the pathology. So we'll start with today's session. The first topic would be on page number 72, whiteout lung. So how do you approach whiteout lung? You need to see if the trachea is central or if it's pulled towards one side or pushed. If it's pulled towards the same side, then the following important things you need to remember. All P's except pleural effusion come under this side, that is pneumonectomy, pulmonary agenesis, pleural effusion secondary to bronchoalveolar carcinoma or pulmonary collapse. Okay. While trachea central is seen in consolidation, mass, ARDS or pulmonary edema. Trachea is pushed to the opposite side in pleural effusion, diaphragmatic hernia and large pulmonary mass. So for certain images have been given, go through the images. All of these are important spotters, especially the rib fracture with callus formation. Callus formation indicates that the fracture is not acute, it has gotten some time before the patient has presented with the x-ray. So next we'll be talking about Sillet sign. What is Sillet sign basically is there will be loss of lung and soft tissue interface due to presence of fluid in normally air-filled lung. So what happens is, due to the anatomical differences between the density of the lung and the soft tissue, we usually see sharp edges at the site of interface. However, this is lost when there is pathology in either soft tissue or the lung, which are present at the borders. So you need to remember certain important things, out of which I would suggest you to remember 3 important ones. So right upper lobe, when it's collapsed, you will see a S sign like this, especially if there is a mass in the upper segmental bronchus. However, you can see in left upper lobe collapse, there is a sign, named sign called left sacral sign. This is due to there is obscuration of aortic node. In right upper lobe, there is obscuration of ascending aorta. Then right heart border is obscured in right middle lobe or medial segment of right lower lobe. Similarly, left heart border is obscured during pathology in lingula or left lower lobe. So just remember these things, and hemidiaphragms are obscured by basal segments of either lobes, lower lobes. So you need to remember these things, and the right upper lobe collapse is seen in golden S, is termed as golden S sign. Then you also have certain other respiratory system pathology signs like Ellis. On X-ray you have Ellis curve, which is due to pleural effusion. Then you have deep sulcus sign and holly leaf sign. And there is a D-shaped opacity due to the incomplete border along chest wall, which is due to loculated effusion. You also have golden S sign, air crescent sign, water lily sign on chest X-ray and or CT. CT you have certain important signs like tree in bud, monod, halo, reverse halo and comet tail. Need to remember the pathologies. And on ultrasound you have the cartwheel appearance of the hydatid. Hydatid has multiple named signs like water lily sign, cartwheel appearance and many more. So you just remember hydrated also. And the most important ones you need to remember is the deep sulcus sign for pneumothorax and monad sign for aspergilloma, and also the finger in glove sign seen in bronchoceles or in ABPAs also. Then there are certain serious diseases which present with named signs. The most important ones are all your TOF, which has boot-shaped heart, TGA, which has agon-side appearance, coarctation of aorta, which has rib notching, which is difficult to see, but there is one more important sign, which is the figure of 3 sign on frontal chest X-ray and reversed figure of 3 on barium studies. Then you have the most important one is the mitral stenosis, where you will see 3 important signs: the straightening of the left heart border, double atrial shadow on X-ray, and antler or moustache sign. For Epstein's anomaly, you have box-shaped heart, and for TAPVC, you have, if it's non-obstructive, figure of 8 or snowman sign. For PAPVC, you however have scimitar sign. Next, you need to remember the certain curly signs. So in curly A is seen in apex, curly B is the one which seen in pulmonary edema due to venous pulmonary hypertension, and it is seen at the base, which is due to the represented dilated lymphatics at interlobular septa. Next, curly C is seen in the mid portion or perihilar region. So eggshell calcification has been asked in INI. You need to remember certain important causes like silicosis, post-radiotherapy, histoplasmosis or any other granulomatous disease, coccidiomycosis, TB, and also sarcoid also. Then you have to remember batwing appearances, and then moving on to the next important thing, abdomen contrast studies. For barium, I would suggest you to remember 3 important ones: achalasia cardia, carcinoma esophagus, and DES. DES has corkscrew appearance. Achalasia has your bird's beak, famous bird's beak or rat tail deformity, and carcinoma esophagus has your shouldered appearance. Other than that, you have to remember 2 important stuffs in barium meal, one of which I have already given as the question for you. So barium meal, you need to remember the string sign for infantile hypertrophic pyloric stenosis and antral pad sign in carcinoma head of pancreas. Then for barium anemia, remember 3 important signs: apple core deformity for carcinoma colon, sawtooth appearance for diverticulosis, and intersusception. You have your coiled spring, claw sign or bull sign. So coiled spring and claw sign can be seen on barium anemia. Bull's or target sign is a ultrasound diagnosis. You also have other important pulled up string signs and other stuffs. You can go through them. Next important thing will be the spotters which I have mentioned. Just go through all the spotters. And then going on to how to differentiate small intestine versus large intestine on X-rays. The important X-rays signs for abdominal pathology. The first one is how to differentiate small intestine versus large intestine. Small intestine obstruction will have air fluid levels predominantly in the central location. However, peripheral location is seen for large intestine. Hostrations will be preserved in large intestinal obstruction. It won't be seen in small intestinal. Instead, you will have volvulae conjunctus. And diameter is one more important thing. Whenever it's greater than 5, it is usually the cutoff for large intestine obstruction. So these are the important things you need to remember. Then moving on to the next important one is the air bubble signs in neonates. So you have the single bubble, the double bubble signs, and the triple bubble signs. So single bubble is seen in pyloric stenosis. Double bubble sign, as termed by the name, is due to duodenal atresia or stenosis, malrotation, or annular pancreas. All the bubble sign are near the duodenum. Single bubble is basically primary kind of thing, so it is seen in IHPS, pyloric stenosis, sorry. And then you have triple bubble signs in jejunum or ileal atresia. Okay. Next are the gasless abdomen on X-ray causes, which is not that important, and the sting signs, which is also not that important, but just given so that you don't get confused. Then we have genitourinary imaging, and on IBP and IBU, you just need to remember certain basics of IBP and IBU, and then remember the contraindications for the same. It is considered as gold standard for obstructive uropathy. So the important spotters in IVP and IVU are being mentioned, some of which are the flower vase appearance in horseshoe, and the drooping lily sign for duplicating collecting system or ectopic ureter, and the reverse J sign for retrocable ureter. Remember these important steps, and also the Christmas tree appearance for neurogenic bladder is classical. Then you have certain MCU or RGU signs, just spotters. You need to remember them. For especially for VUR grading, and for posterior urethral valve, the spotters are classical. You have other important things like diverticulae or neurogenic bladder, and anterior or posterior urethral stricture, and also BVF. Next, we'll go to radiotherapy, radiotherapy basics. You need to remember the mechanism of action, how radiotherapy kills cancer cells by ionization and by DNA disruption, especially double stranded DNA over single stranded DNA. Agents used are the most commonly gamma rays produced through cobalt 60 or cesium 137, and also the X-rays. You also have LINAC and CTCL. LINAC used in cutaneous T cell lymphoma, that is mycosis fungoides, and also proton cyclotrons, where Bragg's peak is the peculiar feature, which might be asked. Then you need to remember certain important radiosensitive and radio resistant structures basically. So M phase is the most radiosensitive phase, while S phase is the least radiosensitive phase. So you need to remember certain structures similarly, and the radiosensitizers and radioprotectors which are used. And you can also remember about inverse square law and stereotactic radiotherapy, which had been previously asked. Then you need to remember about the structures which are the tumors which are radiosensitive and the tumors which are radioresistant by the mnemonic. Whelms are radiosensitive, while HOMP are radioresistant. So radiosensitive tumors is your Wilms tumor, Ewing sarcoma, lymphoma or leukemia, multiple myeloma, and seminoma. Lymphoma, leukemia usually melt with radiotherapy. Then you have radioresistant tumors, all your hepatocellular and renal RCC. Then you have osteosarcoma, melanoma, and pancreatic carcinoma. Next important thing, you need to remember where prophylactic craniospinal radiation is given because of micrometastasis, and also the drop metastasis causing brain tumors. Then modes of radiation therapy which can be asked. The diagrams have been given to you. The important thing in radiation therapy is to minimize damage to the adjacent normal tissue while focusing your radiation on the tumor. So the different modes of therapy are basically made so as to expose the tumor as much as possible to the radiation. So then you have to remember certain important nuclear medicine scans. The most important of them are for detecting microbleeds. You would ask them to do a technetium 99 tagged RBC scan, which picks very small amount of bleed. They say less than 1 ml is also picked by this. Then you have your DTPA DMSA for the urology scans, and also the MIBG scans for all your neuroendocrine tumor, adrenal medullary tumor, pheochromocytoma, and adrenal cortical scintigraphy. Then HIDA scan is for gold standard for your bile leaks, hepatobiliary scintigraphy. And then you have sulfur colloid for your hepatobiliary scintigraphy for mainly for FNH or occult abscess and splenenculi also. Then you have system EB for parathyroids and MPI. Rest of them are not that important. So just remember these three, and also the dotatate one, which is used for neuroendocrine tumors and carcinoids, along with octreotide and SRS. So this will be the end of radiology. There was a lot of overlap with other subjects, but if you have studied well enough in radiology section itself, you can easily go through the overlap sections in other subjects. Thank you for listening. Hope you answered the questions of the previous day in the comment box. We'll meet you tomorrow again for the next session. All the best.